a very good afternoon, good evening, depending on where you're watching this. For those who are watching in the UAE, a good evening to you, a good afternoon to those of our colleagues who are watching it in the UK. And for those who are watching it in other parts of Europe or even further afield, a very good morning to you. Welcome to this second session of looking at digital health. And before we start and I make some introductions, we're going to have just a few slides that just sort of share sort of a vision of where we're going to try and take this next sort of 45 minutes to an hour, and also just give a little introduction of what has happened in terms of our first session and what is coming up. So my very kind colleague, Ben, will be sharing his screen momentarily, and we'll be able to see that coming up. Excellent. Thank you, Ben. And for those who were able to join us for the first session on the 14th of June, you've seen there the understanding around the legal considerations around digitizing our surgical pathways. And actually that leads very well into looking at what we're going to be focusing on today, which is informed consent. And I think what we always have to embed ourselves in that a patient is at the center of everything we do, but we have to understand that both the clinical, operational, legal, and logistical implications of what we're doing, which is why this whole series is really quite exciting. And then we move on later in July with the benefits of the digital preoperative assessment, which is really fundamental because it's about preparing the patient. And I think we're going to be alluding to that later in our presentation when we consider the surgical pathway begins from the point at which the patient engages with the surgeon. And then finally, looking at our anesthetic data capture, I think what is really important is that we're not just preparing patients for surgery, taking them through surgery, but we really want to be able to review and look at the importance of learning from our surgical procedures. And that will be on the 28th of July. Before we get to some of the points here, one thing I do want to just really touch on is that we are really looking across both our colleagues who work in Abu Dhabi, the UAE, and in Dubai, so in our Middle Eastern areas, but also working across the NHS. And you can see some really important stats here. And I think for any of us in healthcare at the moment, we're really concerned of the impact of COVID, not just the immediate clinical impact of our patients, but clearly what is happening for those that we haven't been able to treat due to having their surgery cancelled. And that's not just their surgeries cancelled that have been planned, but those who are still waiting to have the assessment for surgeries. And I'm sure as Simon comes on, and I'll be introducing soon, he'll articulate some of the challenges that we have there. But today we're focusing on the consent process in terms of we've decided to proceed to surgery. But as you can see here, some significant waits because of the pandemic, and not just the impact of the waits operationally, but therefore the pressures we may have in terms of our patients waiting, but also our delays in getting staff to where we need them, because obviously we've had to move and distribute and reuse staff to deal with our clinical caseload. So we're going to come back to some presentations in a minute. We're going to flip back to the screen and we'll see it. And as Ben does that, you will see Dr. Simon Parsons join me on the screen. Simon's a consultant surgeon, has been a consultant since 2001. And not just working across in gastrointestinal benign work, but in a significant amount of major cancer resections, upper GI, esophagus and stomach across the UK. But why Simon's joined us today, which is quite exciting, is his passion around the informed consent process for surgery, not just in his area of surgery, but obviously applicable across the board. Myself, I'm Matt Fitzpatrick. I'm based currently in Abu Dhabi in the United Arab Emirates, working in healthcare there from a strategic and transformational point of view, supporting colleagues clinically out there, not just through the pandemic, but obviously through improving the way in which we serve patients, which is a symbiotic relationship. Patients want to have trust in who they are seeing, but obviously we want to be able to ensure that patients understand the processes that we're putting them through. Previous to that, I was working in the UK in operational management and have a clinical background, but very much pleased to welcome Simon, and thank you for joining, Simon. I'm going to jump straight in with maybe an obvious but almost quite challenging starter is, why is informed consent so important?
Thanks, Matt. Yeah, good question. And I do believe passionately that informed consent is a really important linchpin conversation between the clinician, particularly surgeons, but also any healthcare professional who is carrying out an interventional procedure, and the patient. And of course, the patient is the center of this consultation, and it's all about empowering our patient. I spend a lot of time with my patient, and I'm trying to make a diagnosis, examine the patient, take a history, and then once the diagnosis is clear, I need to move on to what are we going to do about it. And in my case, that's normally a surgical intervention. And during the whole of that consultation, and that applies to whether it's a consultation that's face-to-face, which is the way we've always done it, or in the last 18 months or so, often it's done over the phone or over a video conferencing platform. But during that process, the patient is interacting with you, and they're looking at you, and you're gaining their trust. And trust is really key in that doctor-patient relationship, isn't it? I'm sure that all our clinicians listening would understand that, and that's made much more difficult with virtual consultations, because it's difficult to look people in the eyes and get that trust. But what you're talking to the patient about, and as the conversation moves on to the surgery and the need for a surgical intervention, that informed consent process needs to be done well in order to gain that trust of the patient. And there, of course, are legal responsibilities of the clinician around informed consent. We have a duty to tell them about the procedure, the potential benefits of the procedure, the risks of the procedure, and also the alternatives to the procedure, including the alternative of doing nothing. And that might be the right choice for the patient, but it's important that the patient understands it's their choice, and they need to be well informed in order to make that choice for themselves. So, and doctors are not pushy salesmen. They are providing the facts, they are providing the evidence, and helping the patient to come to a decision which is right for them. And I think if you do it that way, then that trust between clinician and patient grows during that consultation.
And do you feel, and is it maybe more so because of the pandemic and the way we are working at the moment, that requires more of a follow-up or multiple conversations with patients, that you may have got more done in a face-to-face, or have you found it a bit similar in the way in which patients ask of your time?
So I think it's really helpful if the patient is informed before they come into that consultation. Obviously, the old way of doing it, the patient would come, you'd send them off for a test, they'd come back, you'd have the results and so forth. But really what we want to move to is what I call a single meaningful consultation, where all the tests have been done beforehand, and the patient has started to be informed about the process. So they know they're coming to see you about a potential operation for gallstones, let's say, and they've read information about what surgery for gallstones entails. And so when you come to have that single meaningful consultation, you can really focus on the bits of the informed consent discussion that are relevant to the patient. So rather than saying, well, there's a risk of this and there's a risk of that and there's a risk of the other, you know that they've already read that information or digested that information, and they can say, well, what I'm really worried about, doctor, is such and such. And then you can answer that question and focus your time. Time is limited for all of us on those important issues for the patient.
And do you find it's a concern of yours that patients, and all of us, I mean, this is not just patients per se, but when a new piece of information is provided to you, that your retention of the key important parts may not be kept, which, as you know, is an integral part of informed consent, is understanding what you've been told. Have you found that has been more of a challenge in this environment, or do you find that potentially patients use this as a method to reach out more as part of that process?
Yeah, I mean, we know that patients only retain between 5 and 20% of what we tell them, and that depends on the skills of the surgeon. If you can't really understand what they're saying because they're mumbling under their breath and they're using medical jargon, then really you're not going to walk away with any more information. A really good clinician will speak in a plain English or plain whatever language you're speaking in, and will take time to check that the patient has understood. But even so, even with that professional conversation, the patient will still walk out. And I've heard it myself so many times when the relative in the waiting room says, well, what did the doctor say? Oh, I haven't got a clue. You know, and yet they've been nodding and making out that they've understood everything I've said. So that's just it's a big thing, isn't it, for a patient to come and have a consultation with a consultant surgeon, and they often just are not really listening.
And I think that is the challenge we have, but it's usually, as I know, both of us, I'm sure, I definitely myself have been a patient on the receiving end. And even though I've worked in a medical environment all my adult career, you still sometimes feel like rabbit in the headlights, and you are not taking in that information, especially with some of the patients that you will see, especially the cancer patients. Is a huge amount of information that they have got to absorb, which I think as we move along through my questions for you today, I just feel like a bit of a mastermind. So I apologize, Sam, and we will get through them. Is that we want to facilitate and make that an easier process for them, so they do feel reassured, and there isn't just that nod, yes doctor, no doctor. There is we are assuring patients. So let's just tease out, therefore, how can you see the benefit of digitization linked directly to the informed consent part? It's obviously we can talk about it for all, but specifically for informed consent. Yeah,
well, I think for informed consent, it actually helps the doctor, the clinician, the surgeon, and the hospital to ensure that they deliver their legal obligations. In other words, we can prove, using the digital process, you can prove that you have engaged the patient with the appropriate information. So if you deliver patient information on a digital platform, that platform can be measuring the amount of time the patient is scrolling through the information. You can ask questions, simple questions. We're not trying to catch the patient out, that measure the understanding of the patient. And so we've done this in our hospital in Nottingham, and the patients have come to my consultation, and there's a report out that I get a report which demonstrates, well, they've spent 20 minutes reading the information and they've answered all 10 questions and they've got 9 out of 10 right. And I'm pretty reassured then that they have engaged, they do understand, and we can perhaps focus on the question they got wrong and their understanding there. But, there is that legal obligation for us to inform our patients. And this is a way of that happening in the background without the doctors really having to take much trouble themselves. And you don't have to spend the whole of your consultation, which often is only 10 minutes or so, talking about informed consent, because they've already spent 20 minutes or half an hour or an hour reading the information before they've come to you. So that digital process really helps in terms of the medico-legal obligations of the clinician. But it also helps as far as the patient is concerned, because some patients don't particularly like reading, and by offering information in a digital form, you can use different types of media, such as animations, whereby the patient can see what's going to happen to them in simple terms, and sometimes a picture can paint 1,000 words. And so that's a really useful way of doing it. And it also allows the patient to look up additional information if they want. You know, they can click the links to further information. You know, yeah. I don't know about you, Matt, but I see patients as 3 groups there as far as consent is concerned. There's a group who want to know everything that's ever been written about a subject. There's perhaps a majority who want good information, but not too much. And then there's a small group who want to bury their heads in the sand and won't engage with whatever information you offer them. But you know, you can at least, even with that group, you have the duty to provide them with sufficient information.
We're going to come on to one of the animations in a minute that you just alluded to, but before I do it, I'm sort of being jumping around, but you've sort of led into this perfectly, in that one patient fed back to us where I was working that said the benefit about having it on my mobile, because they have it digitally that way, is if it's a bit of paper, I'm likely to lose that bit of paper. But if it's on my mobile, you know, people don't want to lose their mobile. You know, they take very good care of it because your life is on your mobile. And the other one was that I can access it anywhere, but more importantly, I can share it with my family so that they understand, because I think it's a really key important process of anyone going through surgery is your network of your preoperative, postoperative management is your family network or your friend network that will support you. So if they understand at least the nuances of what you're going through, people can, you know, to support in a lot better way. We're going to show the animation in one moment, but before I do, and before it comes up, it's getting ready on the screen. We are going to run a poll in a short while that will ask for those who want to receive further information, for those who want to receive a newsletter following this, that you can just select yes or no, and from your login details that will go back to the team and they will contact you. But we'll run that near the end. But for now, as they say, sit back and relax, and you will see a short animation. So potentially what's happening is that you won't be getting the sound. So I'm going to do the voiceover, and I've been practicing my precious voiceover. So there is a person who's articulating that. It's explaining to the patient that will be obviously a small skin incision. Oh, canal. There we go. Much better voice. She's gone. Don't worry. I will continue. So it explains obviously that there is going to be the opening, and then that the area that of the part of the intestine that's been cut up in the inguinal hernia is released. They remove the inguinal sac that had been formed, and then obviously sometimes depending on the extent of the procedure, there needs to be the mesh added. This is appropriately sutured. You can see the super suture working there away. I'm sure many surgeons would love that automatic suture to be available. And then obviously it's really important about closure and discussing potential positioning of a drain, should that be needed, and then obviously the post-operative management. But I think what it does, it demystifies for patients this scariness of what you're going through, and therefore what to expect when they come out. And I apologize for some of the technical stuff that's, you know, these things happen, but what you can see is it's very simple. Patients can go back to it and look at it, and they can watch that with the written information that they also have. And I think that's the key thing there, that it demystifies this scary, potentially scary surgery. So I think Matt, sorry, please, yeah.
Yeah, I think, Matt, for those who are surgeons, they'll be looking at that saying that's not a very good inguinal hernia repair. But the point is that it's designed for the patient. They don't need to see the detail of the dissection and the various structures. They just want, it's the concepts, you know, that there might be bowel in that hernia sac, and that bowel is returned to where it belongs, and the hernia sac is removed, and then a mesh is done to repair. That's what the patient needs to understand. As a surgeon, I battled with this a little while. I said, I want more detail. But they're not, patients aren't people who are looking to become surgeons. They're not surgeons in training. It's designed for a patient. all they need to do is understand the concept of the operation. And yes, it's a shame the voiceover wasn't working in that, but essentially it is taking the patient through the operation in simple terms, and our feedback from patients has been really positive for all our animations. And as I say, it's a way of delivering that information in a way which patients can just enjoy.
And I think you are right. And that was some of the feedback we've got from some of the leaflets we've used over the time, is that some of the surgeons go, well, it's missing out this, it's missing out that. But you are absolutely right. When you first started your introduction, Simon, it's about plain language. And, you know, they don't need to understand the deep fascia, the deep layers, the multiple sutures that you might have to do, the fact that, because that will almost scare them into thinking that it's potentially more complex than it will be on the day. And that's, you know, that's the reassuring thing. So do you think, and this is a really difficult one, slightly jump into a different strand. We've explained how it can help the informed process. We think that it can help patient safety, because if patients have an understanding, what they'll do is, you know, the anxiety that sometimes goes with these things is a significant concern for patients. Do you think we can use digitization to reduce the backlog that the world is facing?
Well, that's a good one. I think in some ways we can, and it's something we've started doing in Nottingham. And that is that, you know, a lot of our patients have been on a waiting list for 18 months now. You know, I was divisional director for surgery during the pandemic, and we had to report every patient who was waiting more than a year. And there were very few at the beginning of the pandemic. Now there are lots. One of the things we can do for those patients who've been waiting on a list for such a long time, the first thing to do is to remember that some of those patients have not had any problems at all. And let's say somebody with gallstones, actually their gallstones have been asymptomatic all that time. And actually they may not need their operation. You can use a digitization process. You can actually text message patients, do you still want your operation? And we've trialed that in Nottingham, and we've managed to get responses back from patients. And a small but significant proportion are saying, actually, I don't think I need my operation anymore. And then you've got another group of patients who are really struggling with their symptoms and really need to be expedited. They need to be brought to the top of the list. So again, you can use the digital to contact those patients and say, you know, a quick question, how bad are your symptoms? And that may help us to prioritize the patients. Because obviously the emergency and priority 1 and 2 cancer patients do have priority, and we've managed to keep operating on those throughout the pandemic. But it's the priority 3 and 4 patients who, you know, are just on this huge long waiting list, and sort of filtering out those who need their operation more urgently and those who actually don't need their operation. We can use the digitization process to help there.
And do you think there's also a way that the digitization and the information that can be served can do what you said, which is articulate to patients that there may be other things to consider, or you can use to pause? And obviously you don't want to delay anything too long that it then requires bigger surgery, you know, which can be the case in some more, you know, thinking osteoarthritic type conditions and what have you. But there are ways sometimes that we can use digital contact with patients, to make them feel reassured that there is someone who's linking with them, but also then provide them with that reliable non-Dr. Google evidence that is helpful. Do you think that's something that could be further employed across, you know, different healthcare settings?
Yeah, absolutely. So particularly in the orthopedic group of patients, I suppose, you know, what are the alternatives to hip replacement and knee replacement? And, you know, are the patients maximizing those before embarking on the surgery? So, you know, sometimes the surgery is required, and clearly to have them put on that waiting list they made a judgment already, but that may have been a judgment where the balance of risk was slightly different to what it is today, because obviously there is that risk of catching COVID whilst in hospital. And we know if that happens in surgical patients, there's a much higher mortality. And so one of the things that we have to now do, of course, is mention to the patients the risk of COVID. And nobody'd heard of that before the pandemic, and so it wasn't part of the risk balance. So one of the things I think all patients should have now is the up-to-date risks, so the information for informed consent, which include the risk of COVID, and that may switch the balance for the patient and change their decision.
And I'm thinking about the different regions now. So in the UK with digital informed consent, in where I work in the Middle East, in UAE, it is very similar, that it is being used incredibly well. And there's a colleague I work out with, Dr. David Monk, who has been the clinical champion of our digital process in terms of education and how we're going to move this into our, hopefully into our consent process, because everything there, all the notes, all the information that's held, stored and shared is electronic. And the only bit we haven't quite taken forward there is the full digital consent process. And I know one of my other colleagues, Dr. Mohammed Bajane, who works in vascular side. David is a general surgery background like yourself. But being the vascular is sometimes having that information that can be shared quickly with patients across different platforms, to allow them to read it, as they say, before they come in. And in the remote areas where there's a long distance to travel to come and see somebody, if that information is provided from the center, from the hospital that you are dealing with, sometimes you can save a journey to discuss what is quite simple. And that frees up then the time to spend longer with those patients who need those more detailed conversations. Do you think, obviously it's not quite as big a geography as where I am in the Middle East, do you think that's a similar application that could be applied in the UK, considering some of the COVID implications you've mentioned?
Oh, absolutely. I mean, the drive has been, from a financial point of view, the drive has been, let's try and minimize the visits to hospital, and that's a good thing, but it's taken on board a much more important role now in terms of patient safety. If we can deliver this information and the consent process as a remote digital consent process, so the patient doesn't need to leave their home, then they are protected from a COVID and infection point of view. And it absolutely makes sense. Why would the patient want to drive for a long distance, sometimes a couple of hours or more, just to go through the consent process? And yet it is a vital process. We can't just do it, just tag it on to the day of the surgery. The process has to start way before that. And so, the digital consent process that we have with EIDO Healthcare, the whole process is now digital. And so the risks and benefits can automatically be brought into the digital consent form. That can be gone through on an iPad with the patient. You can focus in on the conversation that you need to have, because the patient has an opportunity to say, well, I'm concerned about this, or I don't want you to do this. And you can talk about those specifics, and it's all done in a digital platform. And so, that having everything digital except for the consent process just doesn't make sense, does it, Matt?
No, and that's the exciting thing I think that we're moving towards, because it removes that one bit that is alien to the rest of the process, which is really quite important. And I suppose you've mentioned that EIDO and EIDO are working with you and I across different platforms. I worked with them actually when I was in the UK. Do you think that the benefit of this written information that's shared and that digital tracking, the proof that that information has gone to the patient? Now, we know just because you've sent it, it doesn't mean they've read it, but actually it's an important part in any, and we hate to always talk about litigation and things like medical legal, but it's important to understand that, that unfortunately is an an apparent world we live in. But this helps reduce the litigation, but more important, maybe reduce cancellations, because patients feel informed and not turning up on the day suddenly going, oh, hang on a minute, that's not what you told me. Where you say, well, no, we did. And have you seen those benefits? Although hard to say in the midst of COVID.
Yeah, so we have. So with you mentioned EIDO. So we have looked at the hospitals in the UK that have used the EIDO digital consent, and those that haven't, and we've seen a reduction in consent-related litigation or failure to inform litigation. And that's a big thing in the UK. I don't know how big it is in the UAE, but it's a big thing in the UK, and it's growing rapidly. There was a big legal case, the Montgomery case in 2015, and ever since then, it's really taken off in the UK and in other parts of the world, and I'm sure it'll come to us all. So yeah, and of course, as you say, with the paper information, you can't prove that the patient's read it. You can, and you rely on having written it in your notes in order to say the patient's received it. Whereas, as I've said already, if you're using the digital platform, then you can see that the patient's logged onto it and spent how many minutes reading it and answering the questions. So absolutely, you can demonstrate medico-legal that they have engaged in that platform. And with virtual consultations, you can, which I'm sure we're all doing more and more now because of COVID. You are able to use that same digital platform to deliver that information, rather than say, well, I've got an information leaflet here, but I'll send it you in the post. That's not good, is it? So we want to be able to say, I've just emailed you, or that I've just sent a link to your phone, and you click on it and let's go through it. So having the whole process digitized just makes absolute sense.
And I think the reassurance that I found is that as information updates, we understand different things, on a day-to-day basis. Surgery risks and benefits, surgery techniques update. When we used to have all the printed leaflets, no one was ever great at going around the whole of the hospital and clearing out all the leaflets with the slight change that's happened or the update on this. The benefit we found from the digitization is the moment it's updated across the platform. And there's a version control, and which one has gone to the patient. Have you, have your colleagues and have people reflected on that? And have you seen potentially a cost-saving implication of ensuring that you're not having to constantly reprint, and then circulate?
Well, of course, there is the printing cost savings, but you mentioned a really important point there, that with COVID, EIDO have had to update information every month or so, depending on the COVID situation. And so you don't want to be giving out a leaflet which may have been, in a cupboard somewhere for a year, because it won't mention COVID at all, and that's no good. So you absolutely want to be giving out the latest information. The EIDO information leaflets are always updated whenever there's an important medical change in that procedure. And of course, COVID is an important medical change for all procedures. And so that regular update has happened and has had to happen very regularly. So yeah, the digital platform just makes that so much easier.
We alluded to them, I think I alluded to them earlier, that obviously the surgery is not just the only part, and informed consent is really important. But for those undergoing the majority of surgeries, there is an element of anaesthetic involved. It might be a local anaesthetic for more peripheral things. For those who obviously aren't able to have a general anaesthetic, there's a spinal anaesthetic, or there is general. And that is key and crucial to patients' education as well, because they don't just need to know about what's going to happen under the knife. They need to understand what's there. And we're just going to share one other animation as we continue through this session, focusing on our anaesthetic colleagues and a spinal anaesthesia process.
Animation to show a spinal anaesthetic. Your anaesthetist will ask you to either sit up or lie on your side. You will need to curl up and arch your back as much as possible, as this makes it easier for your anaesthetist to find the right position. A spinal or spinal anesthetic involves injecting local anesthetics and other painkillers into an area called the subarachnoid space near your spinal cord. Your anaesthetist will insert the needle, and when they are certain it is in the right position, they will inject anesthetic through it. This numbs your nerves to give pain relief in certain areas of your body. You can help your anaesthetist by keeping still while they insert the needle. It should not be painful, although it can be uncomfortable. If you feel pain, let your anaesthetist know. As the spinal starts to work, you may feel a warm sensation in the area being numbed.
Thank you again, Ben, and you got a much better voice this time than me droning on, that's for sure. And I think this is a really important process, isn't it, Bam? Is that we need to be working together as a whole MDT team. Patients need to know you're going to be engaging with nurses, you're going to be engaging with surgeons, you might be engaging with anaesthetists, you may be engaging with, in orthopedics, physiotherapy, you might be engaging with other healthcare professionals along the line, so not to be startled if you are contacted. And I think that all is in part of the informed consent. Would you like to add to that? What do you think?
No, I think you're absolutely right. You know, in the UK, the anaesthetists don't take written consent for the anaesthetic procedures that they do, but they absolutely have a legal obligation to inform. And you know, those animations are great for illustrating what spinal anaesthetic involves. So it is absolutely crucial. And yes, whatever discipline you're in, you know, all the invasive procedures that you do, you need to take consent for, whether that's verbal or written. You know, that medico-legally, that's not the issue. It's the information that you're giving and the demonstration that you've shared that information with the patient.
And it's where I worked quite a few years ago. It is a similar thing, but we embarked on creating patient educational videos that showed what it was like to undergo an MRI, what it was like to undergo a CT scan or an EMG, because you know they are scary things as well. You know, to put these patients through these tests, and you know often we get delays because patients can't go in them, and so then that gets frustrating because it's delaying the process to get them down the surgical pathway, and we've all had to work to our targets. Will be a little bit different now in the world we live in, but it's similar. We've got to put ourselves in the place of the patient. So the more accurate, simpler, calmer information that's provided to them, the better. I suppose for me is the patient experience is key, and how we then test that. And you know, we understand that. Locally, have you been doing any specific reviews of the different methodologies you've approached and how patients have found it?
Yeah, so we have done surveys about how well the patient feels they understand the procedure before reading an EIDO information and afterwards, and the understanding goes up very, very significantly once they have read it. I suppose you could say patients didn't know what they didn't know before reading it, but they have definitely understood it once they have read it. I think the other thing that's really important is, you know, these are professional information. This is professional information, and that reflects you as a clinician. You know, as a surgeon, I don't want to be giving out scrappy bits of paper with my drawing, which is rubbish, by the way. I'm quite a good surgeon, but I'm a useless artist. So I'd much rather use professionally done artistic diagrams explaining the procedure and animations and good quality written information. And that shows the professionalism, or you know, reflects on me as a professional and on my hospital. And I understand in the UAE, there's a sort of a culture of second opinions. You know, if you don't necessarily like the first consultation, you go somewhere else. And I suppose for our clinicians, you know, if you're using professional information to impart and share with the patient the important things that they want to to know that's going to help you in terms of people trusting in you as a clinician.
And I think you're absolutely right, that anxiety sometimes that comes where people aren't quite sure and they tend to want to go and ask someone else. And I think that follows the indication of the quality of that engagement that they get, and that mumbling that people, if you're not getting them on side, that's not going to help. But if you can supplement that with high quality, patient focused information, then that reassurance, comes in. When you're booking a holiday and you choose one route to get there or one method to book, and you just don't feel quite right about it, it doesn't instill the confidence that you might want to go stay there or travel by that means. So I think it's the same with the patients. It's a journey that we're taking them on. For me, working with our colleagues out there as well, we have surveyed the physicians, the surgeons, to understand their use of digitization. Has it helped them? And initially, it slows some things down because it's a new system you've got to learn. But I suppose if that's investing now for the future to learn those skills to improve, reduce your cancellations, reduce your on-the-day delays, and reduce the potential and negative outcomes that patients experience or their perception the patient experience. So for you as a clinician using this, how long did it sort of take you to get grips with this technology?
I mean, the user experience is key for the clinician, isn't it? Is making the digital experience work for you in your clinical environment, and EIDO spend a lot of time actually working on that, making sure it does fit the clinical model. And so, yeah, it works absolutely. And I don't have to write reams of stuff on a paper consent form, which I've already talked to the patient. I can import it. It all comes into the digital consent form from the information they've already seen. And it's quite straightforward to check that the patient, you've seen this, haven't you? And yes, and that these are the risks that you've read about, and I see you've answered the questions on that. So it actually speeds up that. And then there's I see you've asked a question here. There's something you wanted to highlight, and so you can focus your consultation on those bits, and it actually makes the whole informed consent consultation focused on that individual patient, because they've done the donkey work of reading the stuff. You as a clinician already know that stuff, but are focused. You've got a duty to impart it to the patient, but you don't have to do that because you know that the process has already been through. So it does make the whole thing a lot easier.
Please, to anyone who's watching, please do drop any questions you may have into the question answer box. But we've had one that's come in and you've sort of just picked up on it brilliantly, Simon. It's as though you're telepathic as well as an excellent surgeon. Is the informed consent process a one-time conversation, or is it something that happens over different points along the patient journey? And you slightly stole my thunder. I think you started to speak about that, but how would you expand on that in terms of the legal and also the professional way in which we deal with patients?
Informed consent is a process, absolutely, and every interaction with the patient, whether it's virtual or face-to-face, should be an opportunity for us to share and discuss the informed consent process. And so I like to start it right at the beginning. If a patient is coming to the clinic with a probable hernia, I'd like to share that information with the patient beforehand, and so that when they come to see me, they know what I'm likely to say, and I confirm they do have a hernia, and yes, I would recommend an operation, and I see you've already shared the information. So, medico-legally, the GMC guidelines, the General Medical Council in the UK is our regulatory body, and make it very clear that, consent isn't just the signature on the paper or the iPad, it is the process. And that's what you need to be able to demonstrate to the legal people if ever failure to inform is questioned. So very much a process. I'm quite comfortable with getting the patient to sign on the day of their operation knowing that they've already been through the process and we've shared all that information, and there is a record of sharing of information. So yeah, very much a process.
One that we haven't touched on yet, which I think is important, is inclusion exclusion. So digital access, digital inclusion. Those who can't access it. I think we've picked up on the language issue because, you know, language has been a challenge for us in healthcare. You know, we've had language line, other services are available. You know, we've had translated stuff. But the digital exclusion, how have you tackled that and dealt with that? So
at EIDO, we have translations, professional translations. I don't mean Google, Google Translate. Professional translations into all the common languages. We also have sign language versions for the deaf, and we also have large print, large print versions for those with partially sighted, and we have Easy Read, which is for those who don't know what Easy Read is, it's essentially a document explained mainly in diagrams for those who have learning difficulties. So those are ways of including those who have particular needs in terms of understanding information. Digital access. If you don't have access to the internet, that of course is an issue that we're grappling with in the UK. One of the things we're looking at is, allowing patients to go to their local library or their local GP practice and have a digital consultation and sharing of digital information at those local centres to them. But it's something that, we absolutely want to include everyone on the digital journey. I think the digital platform makes it easier for people to understand because of the things I've mentioned. But if you don't have internet access, then obviously it's no good at all. And ultimately, you have to have the snail mail paper version as a backup. But I think there are ways of giving access to the internet, even for those who can't afford it at home.
And the other one thing I wanted to sort of tease out as well is, to assure colleagues who are watching this and those who are trying to learn a bit more about it, all the technical translation is key, and that when we're taking things that's been written in English to begin with and then translating into Arabic, into Hindu, into French, Spanish, German, they are proper technical translations, because it isn't medical jargon as well. It's making sure that we don't then just translate it into the medical jargon in another language, because that's going to defeat the object. It's about making it accessible to patients. And these leaflets have been reviewed by patients, and patients have been involved in that journey. Because if you surround yourself by technical jargon all your life, it's sometimes difficult to augment that. And I think the key thing as well, as part of informed consent, and the one thing that I drew out of EIDO when we started using it when I was in the UK, is that it's making patients understand the post-operative expectations, not the post-operative recovery in terms of, sutures out 7-14 days, dressing changed every 3 days. No, the expectation that you aren't going to get back to running a marathon in 3 months. It's the lifestyle changes that have to come is all part of understanding, because some patients, when they grapple with that, sometimes decide to pull back and and take a pause on their surgery, which we were sort of alluding to earlier. So it's really important to have that all-encompassing information. And have you found patients have been very receptive to having that very honestly put towards them, rather than you just need an operation, let's go and do it?
Oh yeah, absolutely. Patients, the paternalistic attitude, which is what you've just described. You need an operation. I'm the surgeon. You need an operation. Just sign here. Those days are gone, and it's very much a partnership. Patients are consumers, and they should be. They should be making the decision. But it is all about appropriate information, and the post-operative stuff is really important, I think, Matt, because as you say, when the patient does go home, they need to know what is expected, and it also helps them know when something's going wrong. If they've developing increasing pain and various other symptoms that might suggest a post-operative complication, they can call for help earlier. And so that's a really important part of the sharing of information. It's not informed consent as such, but it's still part of what EIDO does in terms of sharing that information and you know, identifying post-operative problems early, preventing readmissions and so forth.
You're right, and I think there's such a big thing about this, and you know, reducing length of stay for patients, but not just length of stay by improving their understanding and their journey, but as you say, making sure you understand what's going on and that they don't then come back to hospital, especially with the pressures we are in. I make it 51 minutes past the hour. I can't say which hour because we're all over the world and we'll confuse everybody. But I want to say thank you to Simon. That was really helpful. And I hope those who have been online have sort of gained something from this and understanding the opportunity. Remember, do you know what? Again, the team are amazing. Read my mind. If you want to sign up for our newsletter, click on the button and it will submit to the system and you'll be able to get the information going forward. Thank you to Ben, who's doing all the technical stuff in the background in terms of the slides. But everyone, I wish you well, stay safe, stay digital, and reach out to the team at EIDO. I'm sure they'll be really happy to help and support you with anything to do with your patient journey. So thank you all and have a very good afternoon and evening.